Hey guys, welcome back to my channel, The ENT Resident. If you're looking to know what is atrophic rhinitis, how does it present in a patient, how do you investigate it, and finally, how do you treat it, you're in the right place. Today, I'll be discussing about atrophic rhinitis in short. However, if you want to know it in much more details, I have already made a video on it, which I'm linking up above. You can check it out over there. So let's get started. What is atrophic rhinitis? Atrophic rhinitis is a chronic inflammatory condition of the nose, which is characterized by progressive atrophy of the nasal mucosa and the bones, and hence characterized by greenish yellow crust formation, roomy nasal cavities, and with a very characteristic foul smelling odor. So, this is what atrophic rhinitis is. It is actually a chronic inflammatory condition of the nose, which is characterized by two main features, which is progressive atrophy of the nasal mucosa as well as the turbinate bones. And in the clinical features, the three most important things that you see is greenish yellow crust formation, roomy nasal cavities, and a foul smelling odor coming from the patient. Now, coming to age, atrophic rhinitis usually starts around puberty and it is seen to regress sometime after 40 years of age, sometime around middle age. It is more common in females than in males. Now, coming to types of atrophic rhinitis, there are two types of atrophic rhinitis, primary and secondary, based on the cause. Now, primary atrophic rhinitis is the atrophic rhinitis where the underlying exact cause is unknown. Whereas for secondary atrophic rhinitis, it usually develops secondary to another underlying cause. So, first, let's talk about primary atrophic rhinitis. Since the exact cause of this is unknown, there have been various theories which have been put forward for this. Now, how do you remember? There are seven such theories. The mnemonic to remember these theories is hernias. H for hereditary, E for endocrinal disturbances, R for racial factors, N for nutritional, I for infective, A for autoimmune, and S for surfactant deficiency. So let's talk about first hereditary factors. This disease has been seen to be involving more than one member of the same family in an autosomal dominant inheritance pattern. Second, coming to endocrinal disturbances. Now, this disease is characterized by starting sometime around puberty and it involves female more than males, as I've already said. And all the crusting and the foul smell that is associated with the disease usually tends to cease after menopause. Because of all these factors, it has been hypothesized that there could be a possibility that the disease is a result of an endocrinal disorder. Next is racial factors. Usually, the white races have been seen to be more susceptible than the natives of Africa. Fourth is nutritional deficiency. Now, because this disease has been seen to be happening more in developing countries and less in well to do families or less in the Western countries, there has been a hypothesis that probably this is due to a nutritional deficiency, like vitamin A deficiency or a vitamin D deficiency or even iron deficiency. Fifth point here is infective. Now, from the cases of atrophic rhinitis, many organisms have actually been cultured, and these organisms include Klebsiella ozeni, Perez bacillus, diphtheroids, Proteus vulgaris, Escherichia coli, Staphylococci, and Streptococci. However, even though these organisms have been found in the nasal mucosa, these are thought to be more as secondary invaders, which is responsible for the characteristic foul odor that you get in this disease, rather than being the primary causative organism of the disease. Next, we move on to autoimmune, the sixth theory that is possible here. Here, what happens is a viral infection or some other unspecified agent triggers the nasal mucosal antigenicity. And the body reacts to these antigens which are released from the nasal mucosa by a destructive process, hence leading to atrophy of the nasal mucosa and turbinate bones, and hence the development of atrophic rhinitis. The last theory here is a surfactant deficiency. In a lot of cases, it has been seen that atrophic rhinitis cases, there have been a significant change in phospholipid profile taken from the nasal aspirate. Hence, it has been suggested there could be a possible role for surfactant deficiency. So these are the 7 theories of behind what is the reason behind primary atrophic rhinitis where we do not know the exact cause. Now, primary atrophic rhinitis can be further divided into 2 types based on the histological findings. Type 1 has been shown to reveal end arteritis and periarteritis. Therefore, when you give estrogen therapy to these patients, they actually benefit from the vasodilatory effect of it. Whereas in type 2, you see vasodilatation of capillaries. So, in this case, if you give estrogen therapy to the patient, they will actually lead to worsening of the condition. So, these are the 2 types of primary atrophic rhinitis. Next, we move on to secondary atrophic rhinitis. As I've said, secondary atrophic rhinitis is when it develops secondary to another cause. For example, DNS, deviated nasal septum. So, the side on which it is more roomy, that develops the unilateral atrophic rhinitis. Or other conditions like chronic purulent sinusitis or chronic granulomatous conditions of the nose like tuberculosis, leprosy, lupus, syphilis, rhinoscleroma, vaginous granulomatosis. It can even be the result of a surgery, a complication of a surgery, but the most common cause is usually an excessive surgical removal of turbinates. Other causes can include myiasis, radiation to the face or the radiation to the nose, rhinosporidiosis. So these are about the 2 different types of atrophic rhinitis and what are the causes behind it. Next, we move on to histology. So what do we see in histology? If you had to talk about histology, we'll first divide them into epithelial changes and vascular changes. So can anyone tell me what is the normal epithelium of the nose? The normal epithelium of the nose is a ciliated columnar epithelium. What you see in this image, the first image over here, this is the ciliated columnar epithelium. These are the goblet cells. So this is the normal mucosal epithelium of the nose. What happens here in the disease is that it gets replaced by the stratified squamous type of epithelium, and the cilia gets lost. You can see in the second image over here how the cilia is getting lost and is getting replaced by a stratified squamous epithelium. Also, since the main characteristic feature of the disease is atrophy, you see an atrophy of the nerve elements, you see an atrophy of the ceremucinous glands. Next, we move on to vascular changes. As I've already discussed in type 1, vascular changes are the arteries in the mucosa, the periosteum, and the bone. They start showing obliterative end arteritis and periarteritis. Histologically, you can see this image over here. These are the vessels which is showing obliterative end arteritis. And the bones of the turbinates also undergo resorption, which leads to widening of the nasal chambers. And paranasal sinuses are actually small here because of their arrested development. So these are the histological changes that we see in atrophic rhinitis. Next, let's briefly discuss what are the clinical features. First, coming to symptoms, the patient usually comes to you with number 1, a foul smell coming from the nose. However, this foul smell is actually not noted by the patient himself. However, and the people around this patient usually complain of the foul smell coming from the nose, and this makes the patient a social outcast. And this very important condition is termed as merciful anosmia because the patient is not aware of the foul smell coming from his nose because of anosmia. That brings us to the second feature, which is anosmia. Now, why does anosmia happen in this patient? The 3 factors are: 1, that it leads to a loss of olfactory neural elements. Second, as I've already mentioned, that there's a formation of greenish thick crusts all over the nose. And these thick crusts end up covering the olfactory area. Hence, the air currents which are entering the nose are unable to come in contact with olfactory mucosa. And the third reason is, as mentioned in histology, there is a degeneration of ceremucinous glands. And this leads to xerostomia, and because of which now enough mucus is not available to dissolve the odoriferous materials. So these 3 reasons lead to development of anosmia in the patient. Next, we come on to the third clinical feature, the third symptom. The patient will present with a nasal obstruction, and this is despite the patient having very wide nasal chambers. Why does that happen? Even though there is wide nasal chamber, the patient is actually complaining of nasal obstruction. The reasons behind this is, first of all, the large crusts which are filling up the nose. There is a loss of sensation because of the atrophy of the nerve elements and because of the presence of eddy currents in the nose. Next, we move on to the fourth feature. Now, when you try to remove these crusts, this leads to bleeding from the nose. So hence, the patient can actually come to you with epistaxis. And there is thick crust discharge, already described. Patient can also feel a foreign body sensation in the nose. He or she can present with a Slavic facies where the face is broad and the nose becomes small and wide. Very rarely in unhygienic conditions where the patient has not been treated, the patient can present with maggots. And if these crusts extend to the nasopharynx as well and blocks the eustachian tube, it will result in impairment of hearing. So these are all the symptoms that the patient will come to you with. Now, what do you see when you examine the patient? Generally, you'll find a foul smelling coming from the patient. And when you perform an anterior rhinoscopy, the first distinct feature is the nasal cavity will be full of greenish or grayish black dry crusts, which cover up the turbinates and septum. And when you try to remove these crusts, it leads to bleeding. And once you have removed all the crusts and cleaned up the nasal cavity, you'll see that the nasal cavities are very roomy and there is an atrophy of the turbinate bones. Sometimes, if it has progressed a lot, there can be so much atrophy that you can even see the posterior wall of nasopharynx on anterior rhinoscopy. The nasal mucosa becomes very pale. There can also be septal perforation, and in very extreme cases, the nose may show a saddle deformity. So these are all the signs you see when you examine the patient. And sometimes when it has been very progressive, the disease has been very progressive, you can see similar features in the pharynx as well as the larynx, leading to atrophic pharyngitis and atrophic laryngitis. As you see in the picture over here, first picture here, this shows the greenish discharge and crust formation in the nose. Here in the second picture, you can see a septal perforation. And in the third picture, you see how it leads to the atrophy of the bones. This is the normal image where you see the turbinate bones. And this is the image which shows an atrophy of all the turbinate bones. This is all about the clinical features. Now let's discuss how are we going to investigate the disease. First of all, we need to find out what is there in the nasal cavity and the paranasal sinuses. So first we perform a CT scan of the nose and paranasal sinuses. Here what you'll see is there will be mucoperiosteal thickening in the paranasal sinuses. The maxillary sinuses will be very small and underdeveloped. There will be a loss of definition of the osteomeatal complex because of resorption of all the bony structures. There will be wide roomy nasal cavity. And there will be bony resorption and mucosal atrophy of the middle and the inferior turbinates. You can see in the image over here, you cannot make out any of the turbinates at all. The whole nasal cavity has actually undergone atrophy and resorption. Second, now we need to, the rest of the investigations will be more aimed towards finding out if there is a secondary cause. For example, a nasal swab will help you rule out infective granulomatous conditions. If you want to rule out TB, you can do a chest x-ray, a sputum for acid-fast bacilli, and a Montauk's test. A nasal biopsy will help you in confirming the disease by seeing the histological features. You can perform serological tests to check for syphilis and other granulomatous conditions. For rhinoscleroma, you can do a complement fixation in the initial stages and biopsy in the later stages. And to find out for SLE, you can do a urine and serum protein. These are all the investigations you need to do. Thus, although I feel like this is mostly a very clinical diagnosis, which is made on the basis of the symptoms and the signs that the patient comes to you with. Next, let's discuss a little bit about what could be the possible complications of atrophic rhinitis. It can lead to a deformity of the external nose. I've already discussed if there is too much resorption, it can lead to a saddle deformity of the nose. There can be septal perforation, myiasis, chronic sinusitis, anosmia, chronic pharyngitis, pharyngeal sicca, laryngeal sicca, CSOM, lung abscess, or even psychological problems because of the condition that the features that the patient presents with. Now let's move on to the treatment. Now, treatment, there is actually no specific treatment which is available to cure the disease in case of primary atrophic rhinitis. So, in this case, our main aim over here is mostly towards nasal hydration and maintaining of hygiene, and secondly, to remove or minimize the crust formation as much as possible and the associated foul smell that comes from it. So first will be there are two types of treatment. One is the medical treatment and one is surgical treatment. Let's first discuss what is medical treatment. So the first important thing that comes under medical treatment is you have to do nasal irrigation and removal of the crusts. This is very important to maintain the nasal hygiene of the patient. Here, when you begin treating the patient, usually this is done for 2 to 3 times a day, and as it progresses and it goes to a later stage, you can reduce it depending on the condition of the patient to once in every 2 to 3 days. Now, there are two different materials that can be used for this. First is an alkaline nasal dousing, where we mix 1 part sodium bicarbonate, 1 part sodium biborate, and 2 parts of sodium chloride in 280 ml of water. And this is used to do nasal irrigation. Now, here all three factors, all the three components that I've mentioned here has a specific role. Sodium bicarbonate is alkaline and it creates effervescence for removal of the crusts. Sodium biborate has an antiseptic action, and sodium chloride acts as a vehicle over here. The second solution that is used is a buffered hypertonic saline nasal irrigation, where in 250 ml of water you mix 2 to 3 teaspoon of pickling salt and 1 teaspoon of sodium bicarbonate and use that for nasal irrigation. Second, now that nasal irrigation has been done and the crusts have been removed, you can apply 25% glucose in glycerin to paint the nasal cavity. Here, you dissolve 8 gram of glucose in 30 cc of glycerin. And what is the reason for this? There is a role of both these components, glucose as well as glycerin. 25% glucose is actually a bacteriostatic agent. Usually, the bacteria needs mucin medium for their proliferation and growth. Here, by adding a glucose media, we are actually inhibiting the growth of the bacteria. Secondly, the glycerin is a hygroscopic material, which means that it absorbs water from the environment. So the role of glycerin here is to moisten the nasal mucosa, moisten the whole area of the nasal cavity. And it also kind of acts as a mild irritant and leads to increased vascularity, because one of the pathological features here is that there is reduced vascularity or atrophy of the blood vessels. So this is one of the main important ones that we use. There are other medical treatments like chemicitin anti-ozena solution, which can help in eliminating secondary infection. Estradiol spray, which increases vascularity of the nasal mucosa. This is, however, helpful only in type 1 and not in type 2. Then there is submucosal injection of placental extract, oral potassium iodide, and systemic use of streptomycin, which is used 1 gram per day for 10 days, and this can help in reducing the crusting and the odor. This is very effective against Klebsiella ozeni. This is all about the medical treatment. Let's move on to surgical management. Now, the first main, very popular surgery that first came up was Young's operation. Now, what do you do in Young's operation is you circumferentially elevate the flap of the nose near the alar rim. And what you do here is you place sutures in the center of this flap to close the nostril. So basically, in Young's operation, both the nostrils are actually closed down in a staged procedure where it is performed one side after another in 3 months. And then after 6 months, you open up the nose by removing the sutures and see that sometimes the actually mucosa reverts back to normal and the crusting is reduced. Now, this procedure has its own disadvantages. The disadvantage being, first of all, it is very difficult to elevate the flap. The central suture commonly breaks down. And because you are closing of the nostril, there is no way to do periodic examination or cleaning of the nose. And this also leads to a lot of patient discomfort because of bilateral nasal obstruction. So the patient has to breathe through the mouth. And this procedure is also associated with a higher recurrence. So because of all these challenges, The next surgery that came up is known as modified Young's operation, where instead of fully closing the nose or nostrils on both the side, the nostrils were closed partially, leaving a 3 millimeter gap in both of them. As a result of which, now the patient prefers this because you can breathe through you can have nasal breathing, and both the sides can be done at the same time. And you can even do periodic examination to check the status of the patient. And this is also obviously cosmetically more acceptable. However, this also has its own chances of recurrence, and it does not allow you to clean because of the small gap over there. Other than this, there are a variety of other procedures that have come up, the broad heading of which is because you get a roomy nasal cavity in these patients, the aim to treat symptomatically is to reduce the size of the nasal cavities, and this can be done by various operations like Lawton-Slager operation, where you fracture the lateral wall and displace it medially. Wilson's operation, where you inject a suspension of Teflon in 50% glycerin paste. Then you can insert fat, cartilage, bone, or Teflon strips under the mucoperiosteum of floor and lateral wall and mucoperichondrium of the septum. You can also use triosite and fibrin, and you can also use plastiport implantation. These are all ways to narrow the nasal cavity chamber. Other than this, there are Whitmack's operation, where you do a salivary duct transposition into the maxillary sinus, and a stellate ganglion block, which is done to increase the nasal secretions because there is atrophy of the seromucinous glands. And last of all, there is vestibuloplasty, where a flap is raised from the lateral wall of nasal vestibule and sutured on itself, thus decreasing the lateral flow of air into nasal cavity. This completes everything you need to know about atrophic rhinitis. Lastly, if you had to just think about what could be the differential diagnosis when a patient presents with such cases, it could be a nasal or a paranasal sinus tumor, purulent rhinitis, purulent sinusitis, nasal diphtheria, tuberculosis of nose, gumma, intranasal foreign body, or even a case as rare as nasal cholesteatoma. Usually, the prognosis of this patient includes that it will persist for many years. It will start around puberty, and it will start to reduce sometime in middle age after 40 years of age. This will start to spontaneously recover. So, this is all you need to know about atrophic rhinitis. If you want to know more, if you have any more questions, please comment down below and I'll reply back to you. Thank you.